I'm Dr. Michael Latola, and I'd like to welcome you to this Inclusive Magazine Clinician One-on-One interview with Dr. Natalie Wong from Toronto, Canada. Natalie, thank you so much for coming down.
It's my pleasure. Thank you for inviting me.
Well, you've got a long list of accomplishments, so I'm gonna break them up just a little bit instead of listing them all at the front, because it would take a good solid 10 minutes for me to list all your credentials. It's pretty impressive. But you graduated from the University of Toronto in 1996, and then you didn't become a prosthodontist until 2007. What did you do from 1996 until 2007?
Well, I'm a bit of a slow learner. I didn't realize that I needed to learn a little more. It took me about 7 or 8 years to realize that.
Right.
But in all honesty, when you finish dental school, it's quite an arduous accomplishment,
Right.
and you just want to get out and do some practice.
Right.
And so I was fortunate enough to be able to get into a great private practice. I was the associate with a very progressive general dentist as my principal. And he got me really involved with everything, starting with implant dentistry within my first year.
Wow. So did you place any implants or restoring implants in dental school, or was that not even in the curriculum?
We were very fortunate because back in the early 90s, I don't think a lot of dental school programs incorporated dental implants in the dental school curriculum, but we had Dr. George Zarb. And he's one of our founding fathers of implant dentistry, especially in Canada. He really put us on the mark. And so he was our head of prosthodontics. So as a dental student, we were already introduced to the prosthetic components.
Wow.
With O-rings and overdentures and a little bit of fixed crown and bridge, but mostly overdentures and attachments. And so I feel really fortunate that as a dental student, I was already introduced to it.
Most of my friends that went on to become, whether it was an orthodontist or an oral surgeon or a prosthodontist, did it right out of school. I almost think it's better that you went out and had, this decade of experience as a GP before you went back and got your prost certificate. Did you feel that way while you were getting it, while you were doing your prost training?
Absolutely. It's certainly harder to go back to school when you're used to running a practice and running your own show and earning an income.
Yeah.
And to go back and give that all up and be under someone else's thumb and having someone else check off your rubber dam placement.
You had to do that for a second time, have your rubber dam placement checked off?
That's right.
I would
make sure the anesthesia had taken effect.
Wow. I would assume in a graduate program that they would say, okay, we looked at all that while you were in dental school. We're going to give you a pass on that now.
Well, all joking aside, I am joking about the rubber dam. But they are overseeing, every step of the treatment plan, and they want to see the prep before you take the impression.
Right.
And so it's a bit of a change, to have to go back to that. But certainly, I would not change it for the world.
Right.
Because I feel that having had clinical experience, I went into my program with a thirst for knowledge. I knew what I was lacking. I knew what I wasn't strong in. And I asked to be, given cases with this level of complexity because that's what I'm here to learn.
Right.
And as a dental student, and if you go right away, right after dental school, you're pretty much just an extension of a dental student.
Exactly.
And you don't know what you don't know.
Right.
And sometimes as a student, you don't appreciate how much you don't know, right? And so absolutely without a doubt, I would do it again like that.
Well, you at a time were helping, I know, to run the PROS program at the University of Toronto. Is that correct? Were you involved with the program there?
No, not until I graduated.
Right. No, I mean after you graduated that you had something to do with it. And I would assume that from that perspective, you would prefer to take a student in who had been a GP for 10 years and had some real-world experience, maybe as opposed to somebody who had just come from school.
Absolutely. And different programs look for different things, and certainly a fresh young student out of dental school is able to have maybe more of an open mind.
Right.
But certainly a mature student, someone who's been out a while, can also bring a world of experience and just clinical expertise to the program.
So you're board certified in the U.S. in implants, you're board certified in the U.S. in prosthodontics, and you're board certified in Canada in prosthodontics. You'd be board certified in implants in Canada if there was a board certification like that. I've never been board certified in anything because as a GP, that's not something that we typically do. Tell me a little bit about which one was the most difficult, which one maybe you're the most proud of, and what that process is like to get board certified.
The process is not an easy process, nor should it be. I would have to say the hardest one for me to have attained was the board certificate in implant dentistry. And the reason why I say that is I did that as a GP.
Really?
I did that prior to my prosthetic program. So as you were saying, as a general dentist, you're not prepared for exams.
Yeah.
There's nothing in your training that says, okay, we're going to start to prepare you to take a written exam and start to prepare you to take an oral exam and prepare cases to defend.
Right.
And so going through that on your own and trying to figure out how to study, how to prepare, what to look for in cases that you're going to present.
Right.
You're all on your own.
Wow. Now, how many people, let's say if 100 people get certified, board certified for, say, implants in the U.S. in a given period of time, how many of those will be GPs versus specialists? What percent do you think? Is it mainly specialists versus instead of GPs?
I'll be honest with you, it's mainly GPs.
It's mainly GPs, okay.
Yeah. And I think it's just not as well known that, there is a board certification in implant dentistry.
Right.
And a lot of specialists feel that, once they've achieved they've finished their specialist program, which most of them do incorporate implant dentistry in them, that, they've achieved enough of an accolade with implant dentistry. But I feel very strongly that specialists and GPs alike should challenge the implant board because implant dentistry is multifactorial. It's not restricted to one discipline alone.
Right.
There's a prosthetic element, there's a surgical element, there's a soft tissue element.
Oh, absolutely.
And so in each specialty program, I think you're well trained in your aspect of implant dentistry. You might be exposed to some of the other elements, but a 3-year implant program, I think would cover all of it much higher level than any one program because in your program, you're handling your discipline in addition to implant dentistry.
It really is more multidisciplinary than, say, operative dentistry or oral surgery, right? I mean, you really almost can't perform implant dentistry without really seriously considering the ramifications of the soft tissue just on a single anterior implant or something like that. So there's a written test, oral arguments and case presentation, an oral examination. See, if it was all true false, I would be okay. If it was just like 20 true false questions. It was 3 years from start to finish for you to do that board certification, or how long did it take you?
You can do it all in one weekend.
Really?
Oh, yes. So the preparation takes a lot of work.
That's
finding the cases and putting it together, I would say it's at least a 2-year process.
Right, okay.
Because, and I think this is fair, the board demands that you show radiographs 1 year out.
Right. Oh,
right? Post-prosthetic. Because success is not immediate, it's a long-term definition.
Right.
And so we want to see that the case is successful at least 1 year out.
Right.
So the preparation is at a minimum 2 years.
That's impressive because I don't know that with a fellowship in the AACD, the American Academy of Cosmetic Dentistry, for example, that you have to show your direct composite veneers a year later to show that they're still surviving. So that's a pretty high standard to be held to.
I think so. I do agree that really the true definition of success is 5 years out, 10 years out.
Right.
And so when we look to quote success rates, we try and quote something at 5 to 10 years. But for an exam, in order to make it doable, because you lose patients to other practices, people move, and so it's hard to follow a patient for that long, unless you're in an institution. If you're at a university and you're able to maintain the patient base for a certain period of time. So we want to make the exam doable for the average practitioner.
Right. Yeah. So you're also a diplomat in the ICOI. I know they had their annual meeting this past weekend, and you're a fellow in the AGD, which I am as well. I love that group, and the AAID, and the MISH Institute. That's a lot of fellowships to have. Which one are you most active in? I know that you teach with the MISH Institute. How often do you do that?
Carl Misch is a mentor of mine. I feel very lucky and fortunate to be able to count him as a mentor. He really gave me my entire fire to do implant dentistry and actually to pursue prosthetics as a specialty. And so he's really been a great supporter for me, both emotionally as well as professionally. And so I spend a lot of my time with his institute. He runs 4 sessions of a surgical program in Canada. And he also runs his 2 prosthetic programs in Canada, and so I'm a part of each of them. So 6 times a year, we're teaching.
That's great.
And it's been over 10 years.
Yeah, exactly. Yeah. And most of the people you're seeing are GPs coming into the program looking to start, placing implants or restoring implants, or what is their focus?
We get a mix. There are specialists that do take the course as well, and but the large majority of the people that sign up for the program are GPs. And I think that's wonderful. I don't feel that implant dentistry is restricted to specialists.
Right.
I think that a well-trained GP can do something as well as a well-trained specialist. And I think it's about education.
Right.
I think it's about having proper training, proper mentorship, proper follow-up, and caring about your patient.
Right.
And trying to be the best that you can.
When it came time to place my first implant, I mean, I just always was a little too afraid that, you know what, I'm comfortable doing crown and bridge, I want to stay away from it. The very first one that I did was here at the lab, and it was with a surgical guide. And that took the experience from being terrifying for me to something that was simple, straightforward, and I had a ton of confidence in my ability to do this because we'd thrown so much technology at the problem, and it made me come away from the experience wishing that we had a surgical placement guide for like a 6-unit bridge, you know, or something like that, where you could go in and it would help you to prep and parallel everything and have the right amount of draw. Tell me your experience using surgical guides. I know that you like digital treatment planning. How do you feel about surgical guides for placement? And
so with the CBCT generated guide, I use it the majority of the time.
Right.
You know, I think the biggest limiting factor is cost.
I would absolutely agree.
You know, and with the technology today, hopefully the cost will start to come down. The faster you're in and out of surgery, the lower chance of infection,
right.
the lower pain and suffering, the lower amount of swelling the patient will have, the less amount of bruising. And so certainly the morbidity is reduced if you're in and out quicker, but you have to stay predictable. Exactly. And that's where the guides come into play. Because certainly we want to, you know, increase the success rates with predictability, but we want to decrease the morbidity, and so that's where the guides help us significantly.
Right.
I do respect that you need to have surgical skill.
Right.
You need to know how to freehand an implant, because God forbid the guide doesn't show up, or the guide breaks. You drop it on the floor and it breaks. I mean,
right.
these things happen. And so the hand skill to do freehand implants, I feel, is a very important skill. But we often say that the first 50 implants is your learning curve.
Right.
During that learning curve, would it not be awesome for the patient to not have to go through a...
Yes.
Exactly, the brunt of your learning curve.
Experience your learning curve,
exactly.
Right. Absolutely.
And so certainly the learning curve to do freehand implants is very important. I suggest working with a mentor.
Right.
You know, an experienced mentor, whether they're a periodontist, an oral surgeon, or even a well-trained GP or a prosthodontist who does surgery, you know, mentor under them for the hand skill to do,
right.
you know, freehand implants. But in the meanwhile, do some guided surgery so that you improve the outcomes for your patient.
That's interesting, because usually you surprised me, because most of the people who really like surgical guides are kind of anti-freehanding, because I've always casually said that, you know, if you freehand an implant and get it in the right place, it could have been 2 or 3 or 4 degrees better, probably, with a surgical guide, just because eyeballing it seems difficult. But you surprised me when you said that you still think they should be placed freehand, but it makes sense because you're going to be thrown curveballs every now and then, and you need to know how to react then. So tell me about, as a GP, I imagine that every case you do as a prosthodontist is a full mouth reconstruction. I just have this picture in my mind that every time you walk in, every patient needs, you know, 24 units of crown and bridge or something like that. Tell me about like a typical day in your practice. What does a prosthodontist do on a regular day? Because I'm not sure I know. I've never stood over the shoulder and watched what a prosthodontist does. You probably fix a lot of stuff that we GPs did, but
my practice is a little bit unique, so I don't think that I can compare myself to an average prosthodontist. I'm implant restricted.
Oh, okay.
And I've been fortunate enough to be implant restricted as a GP.
Restricted.
Yeah, I mean,
that's
it almost
an odd
sounds.
term.
Yeah, but you know, it almost sounds like I've been told
won't
not to
let me
do.
Anything but implants. I'm sorry, I'm implant restricted.
And so, but I mean, I was fortunate enough in my GP career,
right.
in my office, to just be working on implant cases. And so, my practice is focused on implant dentistry
right.
alone, and because I do a lot of teaching. I have the Toronto Implant Institute, which I've started in Toronto, and my goal there is to train people. And whether you be a GP or a specialist, whatever you want to get more experience in. You know, I've had the luxury of being mentored by some of the greats in implant dentistry. I've had Dr. Carl Misch, you know, I've worked with him in his office. I've worked with Dr. Mike Picos in his office. I've been trained by Dr. Wong at the head of Perio at Michigan. And I've just been able to look over their shoulder and assist them in surgery. And you learn a phenomenal amount just by watching these great people work. Yeah. Dr. Hilt Tatum, I've worked with him as well. And so I want to be able to share that. My experiences, what I've learned from all these people all over the world has shaped the implant dentist that I am
right.
today. And so I believe in one-on-one training, which you can't get very often.
So tell me a little more about the Toronto Implant Institute. How do you get doctors in? What's the training like? Are they surgically placing and prosthetically restoring?
We started out as a small group of actually GPs. I started that when I was a GP, and we didn't know which courses were good, which courses weren't. And so it was a group of us that was dedicated to learning and to finding the best courses. And we would just tell each other. We would meet, a few times a year and bring cases and troubleshoot with each other. At that point, I was on faculty with Dr. Carl Misch, and so, a lot of them looked to me for some of the bigger cases, especially the bone grafting cases, because they're often a little less predictable than implant dentistry. And so we would share. I have dedicated myself to a lifelong learning. I fly all over the world to learn from people. I was most recently in Budapest learning from Dr. Urban about how to grow vertical bone. And so this institute started with just sharing information, because not everyone's fortunate enough to be able to go to different places. And I would start bringing these speakers in. If I felt there was a value to a speaker, I would bring them to Toronto and run the course there. And so most of the CE is done in the US. Canada's not a huge market for implant dentistry, because just by sheer numbers, we don't have the number of dentists that you do in the US. So I would bring these big name speakers and pay them their honorariums to teach us.
Wow.
And so that's where we all grew together.
So it really started as a study club.
Yeah, it did.
And then grew into more of into a hands-on teaching, it sounds like now.
And so now what we do is, they'll take the course, but a lot of these higher end, techniques, surgical techniques, you can't learn it from watching a video. You can't learn it from a lecture. You need hands-on. And so that's what I'm offering. That, you can bring your patient to my clinic.
Oh, great.
And, we'll cone beam them, and we'll optically scan them, and we'll do a digital wax up and decide what we need to do. And then come in and we'll do the surgery together. You do it, and I'll stand over your shoulder and kind of guide you.
Just that one-on-one interaction, you're right. That's significant learning that takes place there, because, and you'll never forget that, because, the dentist kind of feels like, there's a spotlight on, and you're just so attuned to what you're doing that you're really going to learn. Please tell me a little bit about the Toronto Implant Institute's programs, like the basic program. How many days? Do you have an advanced program? How does it work?
Well, at the present time, we just go one-on-one.
Oh, okay.
So if you approach me, say, I haven't placed a single implant and I'd like to get involved, then I'll set up 6 sessions.
Wow.
Right? Because I feel that 6 sessions, we've got to go through treatment planning and considerations, and we take cone beams and optical scans and learn how to merge data and evaluate data. We're not trying to make radiologists out of people or lab technicians out of people or IT people, but you got to know your anatomy, and you have to know occlusion, and you have to know, how things fit together. And so we'll put 6 sessions together. So we run 1 treatment planning session, we run several surgical sessions, and 2 prosthetic sessions. And so we put 6, sessions together. Someone with more experience, if you say, listen, I've done about 50 to 100 implants, I want to learn how to do some grafting, perhaps, some particulate grafting around some implants, then, we book probably 3 sessions. And we work up cases, and we do 3 surgical appointments with cases, with patients.
That's an amazing opportunity, because I was sure you were going to say, we like to keep the class size small, so it's 6 dentists or 10 dentists. This is literally just one-on-one training like you would get in a pros program.
And we customize it because it depends on what you're learning.
Yeah. If somebody's placing their first one, or like you said, somebody's done 50 or 100 and they want to try something else.
There are enough courses out there that'll group people together.
All of them?
All of them.
Yeah,
so
basically.
you get that. You have to be different. How am I going to separate myself in my teaching institute to give people a different learning experience?
Right. So, even though you probably could make more if you ran 20 people through there at the same time.
Yeah. You know what? We make enough money.
Right.
You pay it forward. You do stuff to treat people well, teach them well, it comes back.
So
I get more referrals from other dentists, because they've taken 1 session or 3 sessions or 6 sessions, and they'll tell their associate, you got to learn from Dr. Wong.
Right. So if a dentist is watching this who's never placed an implant and, keeps hearing dentists should, GP should be placing implants, this is something you can do, whether or not you have a cone beam, what do you think is the best first step? Or what would you say to a GP who wants to get started placing implants today?
I think it's important to get well trained. Okay, and so I think it behooves anyone who's learning a new technique to understand not the didactic, but also the clinical. So you want a hands-on program. Right. You want a program that takes you step by step through the didactic and anatomical and surgical considerations and the prosthetic treatment plan considerations, but also gives you hands-on, first with a model, then perhaps with a pig jaw, and perhaps with cadavers, but ultimately with patients.
Right.
And then if you can find a local mentor, because as you were saying that most of these courses, you don't get one-on-one treatment. You don't get one-on-one mentoring. It's too expensive to do that as a large course. And so then once you've completed a course, find a mentor. Yep. Someone with experience to help look over your shoulder. And most specialists are willing to help you. because there's enough patients to go around. This whole fear of you're going to steal my patient and you're never going to have enough patients if you help someone else learn. There are so many people in need of implant dentistry that we're never going to run out of patients.
Well, I feel like the GPs would be more nervous to ask the prosthodontist because they would be maybe embarrassed about their lower level of skill. Are you saying that the prosthodontist maybe could reach out to their GPs as well and saying, hey, if you're ever thinking about...
I would hope that both lose that barrier.
Right.
Because yes, GPs are afraid to ask their, specialists, but GPs are still going to refer to their specialists. There are cases they can't do, like you had described earlier. There'll be certain cases you feel confident doing, and there'll be other cases you're going to refer. So it's a give and take.
Right.
And so I would hope that specialists would reach out to GPs as well, because again, our goal is more predictable, higher level treatment.
Right.
For the patient. And certainly GPs that are well trained with technology, handling, the simpler cases early on and maybe a little more difficult cases later, can do just as good of a job.
It all comes down to training. How has your placing implants, has it evolved at all since you started? Have the implants changed, or are you largely using the same implants that you used at the beginning? Or?
It has absolutely changed. Something that I love to spread the word on, a mantra that I have. The implant you're using today should not be the implant you're placing 5 years ago, nor should it be the implant you will be placing 5 years from now.
Right.
Because if you are using the same implant for 10 years, you're not utilizing the technology that advances on a monthly basis for the benefit of your patients.
A monthly basis?
I would even say on a daily basis.
Really?
We're just not aware of all the technology and all the research that goes on behind the scenes. I mean, we complain that implants cost a lot, and certainly they do, but all the research and development to make them the 95% success rates that they are today is a result of these companies dedicating so much money to R&D. Yeah, I mean, we as clinicians may not see it on a daily, monthly, 6-monthly basis, but certainly the research that goes on behind the scenes is phenomenal. I think also there's so much more involved with implant dentistry. It's such a much more of a newer field than bonding.
Right.
And so when you have a really good product, how much better can you make it?
Right.
So with the bonding agents that we have today, and again, I'm no expert on that by any means, but I believe they're pretty darn good.
They are.
And so to keep making minor improvements, you don't see a huge leap. Right. But certainly, I mean, the grafting materials we're using today, the bone morphogenic proteins, the bioactive modifiers that we have to enhance bone growth and enhance soft tissue growth, which is ultimately gives us the aesthetics and the longevities for our implants. That grows in leaps and bounds.
Right.
And so all the nanotechnology that we have in implant dentistry has also changed a lot of the success rates for us. So certainly, I mean, you look at one implant company and how many times have they changed their implant?
Exactly.
And it's funny because in the past we used to almost make fun of them. Oh, they can't be that good. They keep changing all the time. But no, the reverse. They're changing all the time because the technology has shown that this surface is better, or this geometry is better, or this nanotechnology is superior. And so, whereas we used to downgrade an implant company for changing, we are now looking to them for improvements.
But in implant dentistry, it's still so new that so many changes are being made that are actually improvements, whereas if you go back to the very beginnings of bonding, you would never be using the same bonding agent like a second generation bonding agent. There's no way anybody would ever use that now. And that's kind of where we are with implants because the field's so young.
Exactly.
And so what are some of those changes that you've seen? Is it surfaces? Is it thread patterns? Is it what are some of the ones that or all of the above?
I would say all of the above. But
do you remember your most challenging implant case?
I would say the most challenging implant case would have to be an edentulous maxilla on a patient that was a chronic smoker and an uncontrolled diabetic. And I'll be honest with you, it's a case that if I had to look at it again, I wouldn't have treated it.
Well, so he's here today. Go ahead and bring it.
But, I think in hindsight...
What would you have done if you hadn't treated him? Just say, look, we can't...
Well, patients
something
present
removable until you get these other health concerns under
control. The patient presented with a medical history that he claimed he was under control for his diabetes.
Right.
And so, you learn from every case. I have a glucometer in the office.
Right.
So if you tell me you're well controlled, fantastic. We're taking a glucometer reading.
Right.
We're
going to call you out.
Exactly. Well, I need to make sure, and it's really for the health of the patient.
Sure.
So you can report on your medical history that you're well controlled. I will actually do a set of vitals now, the preoperative appointment. You know, and so I make sure that things are well controlled. You know, people say they're on high blood pressure medication and they've been on the same medication for, you know, so many years and it's well controlled. Yeah, I take a blood pressure and it's a little high.
Right.
You know, and so maybe we have to have a visit with the doctor. So it taught me a lot. I was probably a little too trusting with the patient in terms of the medical condition.
So did that case not turn out well? Is that what?
No, it failed.
Oh, it failed. Okay.
You know, so I had done bilateral sinus grafts, you know, the lateral windows and the lifts. Failed. You know, I had to go in, it got it all infected. And in hindsight, I shouldn't have even started the case.
Right.
So that was my most challenging. And then once you start to treat a patient, you feel responsible to help them along the way.
Right.
And so, you know, I can't leave them in the lurch.
You don't want to feel like a quitter, right?
That's right.
Exactly.
And so at that point, it became, you know, counseling. But backpedaling is always a lot harder than going forward. And all of a sudden, it became, okay, let's have some diet counseling. Let's have you see an endocrinologist, and let's get this under control, and let's retry the graft. You know, and so we redid the grafts, and another side failed. You know, so at least the first time, bilaterally it failed.
Right.
And then the second time round, one side failed, the other one didn't, but we were, you know, 50% better than where we were.
Wow.
It probably took us 2 years to fix the patient.
Wow.
You know, to get him into a comfortable prosthetic
and
condition.
was it fine? Did his health, everything about his health changing, finally make that possible?
You know, and he started to see that when he changed his habits, you know, the success was increasing, and he was feeling better about himself. You know, and so a positive attitude makes a huge difference as well.
Yeah.
Yeah. So it took 2 years, but he's in a very comfortable position, and I was pleased to be able to see that through. But boy, was that a challenge.
Well, you can't build a house on quicksand, right? Exactly. I mean, he's got to give you some sort of foundation to make this work. Where'd you learn how to do the sinus lifts and all that fancy stuff?
Through multiple programs. Dr. Carl Mish's program, Dr. Mike Picos's program, watching Dr. Wong in Perio. Probably those three were my biggest mentors.
Did that scare you the first time you did it?
No, because I'd watched enough of them.
Right.
Okay, and so I felt that, you know, the whole adage of see one, do one, teach one,
right.
I'd seen plenty.
C20,
by the hands
C30.
of many different people.
Right.
And I'd seen when they had complications.
Right.
So when there was a perforation or a tear, when there was a septa in the way, how to handle those situations. Yeah, when the roots were close by, how to avoid that. And and when there's a mucus retention cyst or a pseudocyst in the way, how to retrieve that and get that out of the way. And how to evaluate the anatomy on the cone beam to make sure the ostium is open so that, you know, bacteria can clear out if an infection develops. And so with all of that armamentarium, I actually felt pretty confident on my first one.
Wow. Did you do it with a mentor? Do you
Absolutely.
remember? Do you remember your first sinus lift? That's a question I haven't asked.
Yes, I do.
Was it... so it was just...
No, it was a patient.
It was
a patient. And I brought them to a program. I brought them to
really?
a course, yes.
So you practice what you preach.
Yeah. I brought them to my Mish course.
Right.
Carl Mish's
how
program.
fantastic. That's perfect.
And
Because
so,
you knew then, that you were safe. It's got to be such a great feeling.
It is. Yeah. So that's why, I mean, we worked up the case thoroughly.
Right.
And I had one of his faculty, one of the mentors overlooked my shoulder, and I felt very confident.
Right. Is that something you guys teach now at your institute, or is that...
Absolutely.
Oh, you do?
Yep.
Okay.
So we'll teach, bone grafting, soft tissue grafting, sinus lifts, sinus grafts, the indirect as well as the direct. We teach block grafting. We teach immediate load, the all on 4, all on 6, all on whatever.
Right. Well, if somebody wants to get in contact with you about taking that course, how should they contact you? What's the best way?
They can look on my website.
And what's the address for that? Remember?
TorontoImplantInstitute.com.
There you go, TorontoImplantInstitute.com. Well, Natalie, it's been an absolute pleasure having you here today. You're a delight.
Thank you so much.
And I love your approach to education. I don't think there's anything more significant than hands-on mentoring in a one-on-one situation, so that's fantastic.
Thank you so much.
Well, that'll wrap it up for our interview today. On behalf of all of us here at the Lab and Inclusive Magazine, I want to thank you for your time and your continued commitment to quality dentistry.